And we request Dr. Pawan Prasher, who is professor in Guru Ramdas Medical College and has been very well trained in cornea and corneal diseases and ocular surface disorders. He to start our session and discuss a very common but very, very important aspect of viral conjunctivitis. Over to Dr. Pawan Prasher, please.
Everyone, am I audible?
Yes, audible very much.
Just give me a minute, let me share the screen. Is my screen visible to everyone?
Yes, Dr. Pawan, we are seeing.
Yes, sir. Yes, sir.
Okay, thank you so much. So, good morning, everyone. At the outside, I would like to thank Academy of Amritsar Ophthalmology and especially Dr. Raman Mittal for giving me an opportunity to make this presentation. And as it's, these are unprecedented times where we are going through a pandemic. And Dr. Raman wanted me to discuss this topic, viral conjunctivitis during COVID times. So I have no financial interest. So to start with, the definition of conjunctivitis, as we all know, it is an inflammation that involves primarily the conjunctival tissue. And as we all know, the normal anatomy of conjunctiva, it is basically a mucous membrane which covers the ocular surface. And we have two main parts, bulbar conjunctiva and palpebral conjunctiva. And on the profile or sagittal section, you can see the conjunctiva reflects on itself, and you have the folds at the upper land known as upper fornix and lower fornix. So conjunctivitis is basically a general term, and it describes diverse group of disorders that affect the conjunctiva primarily. And it can be classified as infectious or non-infectious, and depending upon the duration of involvement, acute, chronic, or recurrent. The presentation can be, it's like a spectrum. You can have, diffuse congestion of conjunctiva, redness, and there can be associated conjunctival discharge, which could be, small in amount, or it could be copious in amount with a lot of matting of the eyelashes, and it just outflows the ocular surface. And sometimes you have this variety which is known as hyperacute conjunctivitis. So the clinical objectives in a case of conjunctivitis is basically, first we need to establish the diagnosis, and it's very important to differentiate it from other causes of red eye, and especially rule out any underlying pathology, because quite often there may be associated disease inside the eye like uveitis and so on. And it's important to identify the basic cause or causes of conjunctivitis, establish the appropriate therapy, and we should try to provide relief from pain and discomfort to the patient, and prevent any potential complications. And also for conjunctivitis, it's important that it's a communicable disease, and we should educate the patients regarding the referring healthcare providers regarding management and preventing the spread of infection, which is more important in these COVID times. So prevalence, there are no reliable figures that can document the incidence of prevalence of conjunctivitis in a population, but from our experience, most of us would agree it is the most frequent reason for ophthalmological consultation, as either as an isolated entity or in conjunction with various other pathologies which we see routinely in our day-to-day practice. Infrequently, it causes structural damage or permanent visual loss, and that's why our management is very important. And in addition, there is tremendous economic impact in terms of lost work time, cost of medical visits, diagnostic testing, and medications, and so on. And so differential diagnosis is like a spectrum of different entities from like infectious, allergic, dry eye, and all foreign body in the eye. All of these can lead to conjunctivitis. And then there can be like some very severe entities like neoplasms, nemasculated syndrome, toxic reaction, uveitis, episcleritis, factitious conjunctivitis, and idiopathic, and so on. So most of keeping the current scenario in mind, my talk will be mostly confined to viral conjunctivitis. And when we say viral, mostly we discuss adenoviral, and then I will try to cover some of the aspects related to COVID conjunctivitis. So viral conjunctivitis, it constitutes up to 80% of all cases of acute conjunctivitis, and however, the accuracy in diagnosing, making the diagnosis as compared to laboratory confirmation is less than 50% only. So we are not always, on target, and many cases are misdiagnosed as bacterial conjunctivitis. However, majority, like 65 to 90%, are caused by adenovirus. And common viral conjunctivitis causes so far in literature include adenovirus 2367, which causes pharyngoconjunctival fever, and serotypes 8, 9, and 37, which is known to cause epidemic rate of conjunctivitis. Then there are herpes virus, measles virus, and Epstein-Barr virus, which is they are also known to cause conjunctivitis, but these are like separate entities in itself, herpes especially. And now the addition to this list is the COVID-19. Continuing with adenovirus, you have like two types of manifestation: pharyngoconjunctival fevers, where you have abrupt onset of high fever, pharyngitis, conjunctivitis, and preauricular lymphadenopathy, and another is epidemic conjunctivitis, which quite often you have like from swimming pools and schools, colleges, and so on. You have these epidemics. It's more severe, and the patient presents with watery discharge, hyperemia, hemosis, and infiltrates lymphadenopathy. So, in a nutshell, adenovirus accounts for majority of cases of acute infectious conjunctivitis. Usually, it is self-limited and does not really require antimicrobial treatment, but it is highly contagious, and that's why it's known as epidemic rate of conjunctivitis. And patient education is one of the key measures to reduce the risk of spreading. And as a practicing person trained in cornea and external diseases, we see all different types of pathologies, but one disease which I am quite afraid of is conjunctivitis, because quite often we ourselves can get infected. And a couple of years back, I had, when I was examining a patient, I had it on myself, and it took more than 3 weeks for me to fully recover. So we need to prevent ourselves, and we need to prevent the spread of the any infection. So it's very important to educate our patients. So this adenoviral usually presents with intense hyperemia with thin watery discharge. And this is a characteristic picture. You have diffuse congestion, which is more prominent in cornices. And you ask the patient to look up and retract the both eyelids down. And even if you see from a distance, you can quite often, make a accurate diagnosis. And the follicles, these are the hallmark of the adenoviral conjunctivitis. But sometimes you have like hemorrhagic variants, which presents with subconjunctival hemorrhage also. As I said, most of these patients, they recover by itself, and but there are some complications which we as ophthalmologists should be aware of, and we have to treat them accordingly. Pseudomembranes, these are sheets of fibrin-rich exudates lacking blood or lymphatic vessels, and usually they are adherent to the tarsal conjunctiva. And another is subepithelial infiltrates, which are basically aggregates of immune reaction against virus antigens, and can persist from weeks to years. Usually resolve without scarring, but we must be able to pick up and counsel the patient appropriately. Bacterial superinfection is rare. ER can be severe in pediatric patients, and then you have to treat accordingly. Just a representative picture of pseudomembranous conjunctivitis. You can see this gelatinous sheet on the tarsal conjunctiva, where the lid has been inverted, and on the lower eyelid on the undersurface, you can see this pseudomembrane formation. These are representative picture of subepithelial infiltrates. Sometimes they are visually troublesome because they are in the pupillary area, and patient has problem of like fluctuating vision or not being able to focus properly. On high magnification, and you can make like a narrow slit beam. And so another picture. So as I said, they usually resolve over a period of time, and you just need to counsel the patient and give him time. Diagnosis for adenoviral is based on signs and symptoms. Laboratory tests are not necessary but can be helpful. These are various tests. We all know these entities now: rapid antigen immunoassay, PCR is the confirmatory test, but other tests are direct immunofluorescent and cell culture. Cell culture used to be the traditional definitive test, but recently we had this test known as Adeno Plus. It's a rapid pathogen screening test, and is based on direct sampling microfiltration, and similar to the home pregnancy test, there is a strip on which you touch the tears, and it has a very high sensitivity and specificity. So this is this Adenoplus test. You touch it onto the tear film and run the test. Give it like a 10 minutes, and you have different interpretation. If there is a red line, it's a positive, and if there is no red line, then it's a negative test. So that way you can confirm whether it's really virus or some other entity. You can manage the patient accordingly. Treatment usually self-limiting, complete resolution in 3 weeks. There's no effective you can say treatment, definitive treatment. Artificial tears, topical antihistaminics and cold compresses to mitigate the symptoms. Antivirals there is inadequate evidence, and the role of steroids is controversial. As I said, ganciclovir has been shown to experimentally decrease the virus load, but in clinical trials it did not really made a difference. So most of the people do not really use it. Antibiotics are as such not indicated. These are guidelines from American Academy of Ophthalmologists. We in India tend to give, because we are not quite often, we are not sure, so we tend to add an antibiotic ointment just to prevent any treat any coexisting bacterial infection or prevent super infection, but they are not supposed to protect against secondary infections. Also, their injudicious use may complicate the clinical presentation by causing allergy and toxicity, and also there is a risk of spreading the infection to other eye. If you give a dropper and patient has to you put it in both eyes. And increased resistance is also of a concern, obviously, because especially with fluoroquinolones and so on. Like other drugs also, pseudoephedrins, interferons, dioxycytidine, etc., but these are not commonly used. Steroids, just as few points, because it's a controversial topic, and a lot of people, they have different take on whether to use steroids or not. They have a transient elevating effect in acute phase. They are known to prolong viral shedding in animal models, and disease and infection duration could be controlled. There is a potential, and most people agree that it should be restricted to complicated cases with pseudomembranes or subepithelial infiltrates, where there is a risk of visual acuity getting impaired. And it's very important that patients should be instructed to maintain precautions for 2 additional weeks after resolution of the symptoms, and patients on prolonged steroids should be periodically monitored for his IOP or development of the cataract. And follow-up, we need to evaluate these patients for developing subepithelial infiltrates, which occur 1 or more weeks after onset of the symptoms. Treatment varies with severity, and in mild case, as I said, you just consult, provide reassurance, observe, but in severe cases, you have to, where patient has blurring, photophobia, or decreased vision, you have to add topical steroids in a tapering manner. And another slide, just to highlight the role of topical cyclosporin, which is a steroid agent for treatment of these infiltrates. And cyclosporin does not really help in acute symptoms, nor it affects the natural course of the disease, but it reduces the formation of subepithelial infiltrates and provides relief from symptoms like foreign body sensation and visual impairment. Recently, some of authors, they have used this modality, excimer laser phototherapeutic keratectomy, to kind of remove the subepithelial infiltrates and provide visual improvement. So it's a known entity now. Now, coming to the second part, approach to conjunctivitis patient in COVID time. So most of the precautions which we take for adenoviral are we take it over and use our whatever we learned from this in COVID with more stringent measures. So we must keep in mind that any patient coming to the clinic with a red eye in today's time should be suspected of COVID conjunctivitis until proved otherwise. So what are the concerns as ophthalmologists in our today's time? First is the possibility of this condition being a presenting symptom of COVID-19, and second, risk of transmission from the tears from these patients. So what do we do as ophthalmologists? So our aim is basically we need a balance, professional and ethical balance between becoming hotspots for viral transmission, and at the same time we have to provide the required essential ophthalmic services to our needy patients. So what are the why the ophthalmologists are at risk to contracting the disease themselves? Because one is the presence of virus in the tear fluid, which has been demonstrated now. Earlier there was a lot of confusion, but now the studies have come out that it is present in the tears. So it's like the percentage of patients which exhibit is very less. Secondly, as ophthalmologists, we have to really go very close to the patient. So proximity of encounter, while examining the patient is a risk factor. And third is deceiving symptoms. And we know that COVID, it can deceive you and it can present in so many different ways, and we may be caught off guard. So just a little bit, I'll just try to cover the highlights. The presence of virus in the tear fluid. We know that there is a ACE in receptors, which the virus is supposed to attach to these receptors, and these receptors are present on the cornea and conjunctiva. So these can be at a potential entry points. And the coronavirus, which has been extracted from conjunctival discharge and from the tears. So while examining the patient, the risk of tears contaminating the fingers of the examiner as well as the instrument is fairly high, and we need to be cautious about it. Second, proximity of encounter. So we go while examining the patient, we go very close to the patient, because that's how our profile is. Even on the slit lamp, we are very close, like 20 to 30 centimeter, and there is a very risk of getting in contact with conjunctival discharge, tears, nasal or oral secretion if the patient is sneezing or coughing, and this can pose a hazard to the ophthalmologist. And deceiving symptom, as I mentioned, so we may be caught unaware, because conjunctivitis may be one of the first signs of COVID-19. And with these reasons in the background, it is important to have practical and useful guidelines tailored to the local needs. So we have all sorts of guidelines from American Academy and so on, different societies. All India Ophthalmological Society has come out with its own set of guidelines, which has been recently published in one of the issues of IGO. And we all, I believe there are a lot of students on the panel listening right now, and it's very important you should go to all those guidelines. Just in a nutshell, AIOS recommends that patient with conjunctivitis should be seen in a designated OPD room with an isolated waiting room by a designated ophthalmologist. And since conjunctivitis is reported as a part of spectrum of COVID-19, all patients should be treated as COVID-19 suspects, and they should be examined in isolation with slit lamp breath shields, N95 mask and disposable gloves. And I'm sure all of us are doing it right now. Just to show you a picture of the breath shield at the slit lamp, and obviously social distancing, it's a new terminology, but now all of us understand it very well. So three-pronged approach is recommended. First is protecting ourselves and our hospital staff from getting infected, providing maximum possible care to the patient while minimizing the risk to other patient. And we have to contribute and play a critical role in controlling the pandemic by screening patients, maintaining the contact details, symptom survey, keeping track of them, and guiding them for appropriate referral to the COVID testing or quarantine centers. And so there are a lot of strategies. I'm sure Dr. Raman will cover a few of them in greater details. Various non-pharmacological intervention, what we are supposed to do in OPD, what outside hospital, in operation theater, personal protective equipment, hygiene practices, and so on. And there is a wonderful article by Dr. Jagatram's group in Indian Journal of Medical Research covering these aspects. And that's a recommended reading for everybody. And there are various aspects: thermal scanning, social distancing, tries, elective procedure be referred, and so on. So hand sanitizer, hand washing, and so on. All these things are they are very important in protecting ourselves and protecting the spread of the infection. A little bit about ocular involvement in patient with proven COVID infection. We all know it. COVID-19 patient may have like variety of symptoms. They may be asymptomatic, or they may have various symptoms like fever, cough, breathlessness, muscle ache, fatigue, loss of smell, taste, headache, blood in vomit taste, diarrhea, and eventually they go into hypoxia and so on. But a few of these patients may present with conjunctival redness and conjunctivitis, and this is a study in China where they found that this subgroup has a leukocytosis with increased neutrophil numbers and various different higher enzymes like calcitonin, C-reactive protein, and so on. And ocular features in one study was found in 1/3 of the patient, included conjunctival hyperemia, chemosis, and tearing. And strangely, while 91% of these were positive by RT-PCR, only 16.7% were test positive for conjunctival swabs. So conjunctival samples or tear sample may not be a definitive diagnostic tool to establish this diagnosis, but the virus has been found there. In over 1,000 patients, only 9 patients had conjunctival congestion. So different authors have different views. Studies have different views how this thing. But we must be very we can say receptive to the idea that any patient, there is no clear-cut consensus about this manifestation. But any patient for conjunctivitis should be suspected to be COVID-19 positive in these days. And symptoms, as I said, myriad of symptoms. First contact tracing patient had only itchy eyes. Then another study, they had, many of them, 4% had conjunctival congestion, and then other symptoms include dry eye, blurred vision, foreign body sensation, itching, photophobia. So you never know what complaints, the patient may present, and we have to be open mind for all sort of these complaints that patient may be suffering. And for practical purposes, as shown by Dr. Jagatram's publication, the clinical features include just like what I discussed for adenoviral, itching, dry eye, blurred vision, photophobia, pre-auricular lymphadenopathy, chemosis, conjunctival congestion, follicles, and tearing. So nothing extra or special. And there has been no documented report of any retinitis or uveitis so far as of now. And fundus photography has, in some of the patient has been unremarkable. And differential diagnosis, all those causes which I covered earlier. And the algorithm has been, in addition to this published in IJO by Dr. Rohit Shetty. So how the patient comes, how it has to be traced, and all the different precautions, they should be carried out meticulously, examined in a separate room, and so on. And all these patients should be treated as COVID positive. And the final treatment was targeted towards the most common cause, that is viral and bacterial conjunctivitis. And straightforward treatment would be medications initially should be provided without doing a detailed examination. That's what they recommend. If you suspect only conjunctivitis, they recommend that we should give we should have pre-packaged combination of antibiotic and lubricant, and preferably without doing detailed examination. At first go, you can prescribe them, like a combination of fluoroxacin or moxifloxacin eye drop 4 to 6 times a day, along with a carboxymethylcellulose or sodium hyaluronate 4 to 6 times. So preferably, as I said, a pre-packaged, pre-prepared package should be available, and it should be dispensed immediately to the patient, and then patient can be monitored or tracked through teleophthalmology on phone or something. And supportive treatment, ibuprofen is better avoided because it has been shown to worsen the systemic effects of COVID infection. Oral paracetamol can be added instead. It is best to avoid topical steroids during the pandemic as far as possible, because we may not be in a position to bring the patient back on frequent follow-ups to monitor any secondary complication like increased intraocular pressure. The patient should be contacted within 2 weeks, and if there is an worsening or emergency consultation, then probably you have to make the patient come in earlier. If the patient is symptomatically better, you can continue with the same treatment. But if he worsens or develops any respiratory infection or something like that, then patient should be referred to the COVID hospitals. And if just there is worsening of conjunctivitis, you may consider adding topical steroids for some time. So, in a nutshell, we must remember by itself, COVID conjunctivitis would resolve without any morbidity if systemic complications do not occur, and we should, in the meantime, try to reassure the patient, treat the symptoms, and do as much as possible in educating the patient, and so that there is no spread of the infection to in the community. To conclude, the basics of managing conjunctivitis remain the same. The algorithm approach is basically, it has to be utilized in conjunction with your existing experience. All of us have been managing conjunctivitis, in all the time our practice, everyday basis. And ophthalmologist, it's preferable they should work in tandem with infectious disease specialists whenever possible, or they should be in contact with their local societies for guidelines and instructions. Until the time a cure is developed, artificial intelligence-based platforms as well as teleophthalmologists should be encouraged. So thank you so much for your attention.
Thank you, Dr. Prasher. It was a wonderful, illustrative, and very elaborate presentation on conjunctivitis, viral conjunctivitis, and especially in COVID.